I'm Arnie Epstein. I'm chairperson at the Department of Health Policy and Management at the Harvard School of Public Health. I'm a physician by training and very interested in issues that have to do with quality of care and access to care. There have been a series of studies going back literally 40 years showing that across different geographic regions of the country, regions that look fairly similar to each other, there is a remarkable difference in the way they use medical services and the amount of money they spend for medical services. And we've known that for 40 years. And sequentially over time, we've learned that despite those differences in spending, we can't detect much difference in medical outcome or patient satisfaction with care. The studies have been bedeviled by the fact that they're put together by large administrative claims, which contain only gross information about patients' morbidity, comorbidity, and severity of illness. But now more recently, and that's the study that we've seen published recently, they're using finer and more nuanced information obtained from patients about their functional status and the diseases they have. And even when you control for that information, there seem to be still residual differences of substantial magnitude between different geographic regions. Not that we can detect. Again, the methods we have tend to be pretty gross. They're population-based studies, but there have been studies of patient satisfaction and there have been studies of mortality rates and the like, and we don't detect much difference, which is what's bedeviling. You know, the simple-minded approach would be that you'd go to the high regions and expect to find that those doctors were doing a whole lot of services, ordering a lot of diagnostic and therapeutic services that really weren't necessary. We don't really find that. When you look at the appropriateness of care and you ask questions about whether there was a higher rate of inappropriate care in high-spending regions, you find out, no, not really. It's pretty much the same. And the answer seems to be in higher use of a series of items of care for diagnostic and therapeutic purposes that we might call discretionary. Doctor has a patient who comes in with hypertension, they're stable, need to be seen again, sure to be monitoring, but do you see him in 2 months? Do you see him in 4 months? Do you see him in 6 months? Or do you tell him to come back a year later? And we just don't know the answers to the optimal periodicity for questions like that. Well, the differences in spending appear to be across the entire spectrum of care. Having said that, for most people, as they get old and sicker, spending increases. For people above 65, it's much greater than for people lower than 65. And if you were able to look at people in their last year or 6 months or 2 years of life, it is understandably higher. I think the people who put together the new legislation were cognizant of these geographic variations, and I think they've put together a number of policies that go into effect that should start to address this issue. On the one hand, they've put together policies that should educate doctors and provide information that doctors need to know amongst discretionary care what's the more appropriate way to go and what's the less appropriate way to go. There's a substantial amount of funding, actually most of it came in the President's stimulus package, for what's called comparative effectiveness research, and that should help. And there's also tremendous interest in speeding information technology, speeding its dissemination, so that we can take the knowledge and the decision support that is generated in the research community and bring it into play for practicing doctors. So those should be very helpful. And then on the other side, there are a whole series of changes in reimbursement, pilot programs, demonstrations, and the like, to try and put together programs that would incent docs not to say, why not get it, but instead to say, do we really need it? Things like that. Well, let me just take two, for example. One is an effort, what you call bundling, to combine the resources or combine the interests of multiple providers. For a patient who goes in hospital, it might tether together the spending that's done by the doctor, by the hospital, and by the post-hospital facility that might take care of the patient. And by bundling all those services together and putting a fixed price around them, It would incent those providers to work together to avoid cost shifting, and if possible, to decrease readmissions, which might be costly and expensive. So that's one approach. Another approach has to do with shared savings, and that the idea here is to get different medical care organizations to undertake care of a whole range of services for a patient, again for a fixed price, and they would be given a single amount of money for all of those services, and in addition expected to meet certain quality targets so that we knew that care was really the best care that doctors can provide. I think it's already kicking in. It was part of the stimulus package, and so there are substantial funds that have to be given out as part of that package last year and this year, and so we're going to see some impact from that. But I think in addition to whatever impact we see near term from those projects, we're going to see a longer term impact because we're going to learn about the types of places where additional research funding on comparative effectiveness will yield the biggest bang for the buck. The government is embarked on a program now to try and reduce spending, but do it in a way such that quality of care is preserved. They've put together a whole series of different proposals that will affect the incentives that doctors have for providing more services and less services, and the tools they have for deciding which services are most helpful for patients. I think this is a good way to go forward, and I look hopeful we'll make substantial progress in the coming years.